My name is Adrian Turner. Thank you so much for the introduction, and thank you so much for having me here with you guys today. Generally in practice, a lot of the questions I get are pretty practical. What interactions do we have with medications? How can we add a specific medication on to help reduce these seizures? But a lot of questions I get from families are administration-based. How can I crush and mix this tablet? What do I do if my child can't take anything by mouth? And so today I'm going to be discussing these practical considerations for you guys that you can apply at home when you are in these situations. I don't have anything to disclose, but I would like to point out that I will be discussing off-label uses and administration techniques during this presentation. By the end of my presentation, I would hope you guys are able to walk away by being able to identify opportunities to optimize your anti-seizure medication regimen when your child can't take anything by mouth, that you would be able to distinguish medication characteristics that would minimize the risk of side effects when administered enterally, and finally that you would be able to identify enteral administration techniques that would further support efficacy as well as mitigate those side effects. So something you probably already are very familiar with, antiepileptics. We use these, as mentioned in several great presentations yesterday. This is our first line option as far as treatments for epilepsy. It's usually our go-to. But the thing is that these work best when we stick to a schedule. We want to keep that seizure threshold high so our brain is able to control those seizures. But sometimes things change. Things happen. So administration and formulation type can affect the level of medication circulating in the system. And sometimes things happen, life happens, and we miss doses, we get off track. So all of these things are usual occurrences, but these are definitely manageable, especially with planning for these situations. One of the most frequent causes in our patients for not being able to take a medication is preparation for surgery. And the biggest thing that I always counsel my families on is communication. It's very important to communicate with your healthcare providers and your healthcare team, not only prior to the surgery, but the day of surgery. Things you might want to ask are, is my child going to be strictly nothing by mouth or NPO? This would mean no liquids, no food, and no oral medications. If that's not the case, would your physician be okay taking your medications orally or enterally? If they are a strict nothing by mouth situation, then how long is that procedure going to last? What other alternative routes do we have for our antiepileptics? And then, of course, there's the non-surgical reasons, especially this last year, several acute illnesses, nausea, vomiting. Sometimes we can't keep food down. We can't keep our medications down. There are various disease states affecting the GI tract, such as cyclic vomiting syndrome, delayed gastric emptying, or even as simple as a food intolerance or oral aversion. So questions we ask are the nausea and vomiting treatable? Can we mitigate that so we can keep our medications down? That's ideal, but sometimes that doesn't happen. Another question would be, will my child require a feeding tube? And if so, what type? Because that will affect how we recommend you administer those medications, and that could affect the absorption of the medications fairly significantly, depending on how you administer it and where you administer it. So we've discussed strict versus not strict, and we've established that, yes, it's ideal if we can give our medications as we normally do, because we've established that works for our patients. But the good thing is that we have several alternative routes. We have intravenous, we have intranasal, we have rectal, and we have intramuscular. Intravenous is our favorite. When we can't take anything by mouth, intravenous allows the medication to be absorbed rapidly and almost fully into the blood system. But this may require more frequent dosing, so there may be an alteration in how we normally dose your child. If your child is unable to have an IV, or that medication doesn't have an alternative, an IV formulation, we often use intravenous benzodiazepines or an intranasal benzodiazepine. So that leads me into my intranasal route. The intranasal route works very well because our nasal mucosa is highly vascular. So when the medications are administered nasally, it gets absorbed fairly rapidly, especially compared to our other routes. Similar to intravenous, it's not always a one-to-one conversion on our doses, but that's why you have your pharmacists and your physicians to help guide that treatment change. And it's a really good alternative when an IV is not possible. Thirdly, we have rectal. Similar to intranasal, the rectal mucosa is highly vascular, but to a lesser extent compared to the nose. Usually this route takes a little longer to absorb, so it is an option, but it's not our normally preferred option when we're trying to replace a maintenance antiepileptic. And then finally, intramuscular. So I work in the pediatric realm. This is not necessarily our preferred method. Children are constantly growing, changing, their body composition is very different, and that body composition affects how medications are absorbed. Because of this reason, it's not always reliable, and sometimes the absorption is a bit more slow. In adults, this is a completely feasible option. It's a bit more reliable, may take a little longer than intravenous to act, but it is still, it's more important to get the medication than to skip your dose. So we're going to go through a few examples. We're preparing for surgery, and we have 3 different children. They're on phenobarbital, cannabidiol, and levetiracetam. So phenobarbital, we have both intravenous and rectal administration. IV is preferred, but the rectal is an option if your physician would prefer to remain on phenobarbital instead of trialing a different alternative. Cannabidiol, unfortunately, it is only available by mouth, so there is no intravenous, nasal, rectal, intramuscular formulation. The good news is that we could utilize intravenous lorazepam or intranasal midazolam in the interim. And then finally, levetiracetam. This one has quite a few alternative formulations. Intravenous is great. Levetiracetam, that dosing is equivalent 1-to-1, and it's a pretty easy conversion for both the healthcare team and the patient. But again, if that route is not available, we do have alternatives to even intravenous. So circling back to those questions we want to ask during surgery, the biggest thing is how long is that is that nothing by mouth period going to take? If it's short, sometimes it's reasonable just to resume the antiepileptic immediately after the procedure as soon as they're back. The key is that this is dependent on half-life. So we're getting a lot of pharmacology lessons today. We have mechanism of action, and now we're getting half-life. So half-life is the time it takes the body to break the medication down to where the levels circulating in your body are cut down by half, hence half-life. So the longer the half-life, we have a bit more wiggle room. So for example, cannabidiol, we don't have an alternative, but it has a very, very long half-life, both the parent compound as well as its metabolites. So it does stay in the system. And this medication, from my standpoint, if we have a very quick procedure, I'm not too worried about the levels getting too low. We have a bit more time to find alternatives. Compared to levetiracetam, it is fairly short comparatively. So this would be an option or a situation where the healthcare team would collaborate and come up with a plan for your child to find an alternative if needed. So phenobarbital, we've established intravenous is our preferred. Similarly to cannabidiol, it has a fairly long half-life. So our first option is to go ahead and convert to intravenous. If we cannot, for any reason, administer this medication orally or intravenously, we have a pretty wide window of the levels in your serum remaining fairly high. As we've discussed, cannabidiol, long half-life, so we have a bit wider of a window, and levetiracetam IV, but if IV is unavailable, we can utilize another alternative such as rectal. So enteral administration. This is one of the most common questions I get from my parents as well as my providers. We frequently convert from oral to an NG tube, a G button, a jejunostomy tube. But the biggest thing I want to relay to you guys is product selection and administration technique can go a long way. So general product selection tips would be to avoid anything that is extended release or delayed release. If we crush that formulation, usually what happens is the full day's dose gets released at once. So you're at risk for over-medicating and putting the patient at risk for more side effects. So immediate release is preferred. There are some exceptions, but we will discuss that momentarily. Elixirs and suspensions are generally preferred over syrups. Syrups tend to clog the tube more comparatively to the elixirs and suspensions. And liquids, again, are easier to administer, but they're not without our risks. Liquids do sometimes contain high amounts of sugar, alcohol, or have a high osmolarity, and that increases the risk of GI side effects and discomfort, which we want to mitigate. So osmolarity is the amount of the medication in a volume. So usually higher osmolarity, you can see on the right, it's a bit more concentrated. And so the more concentrated that medication is, it's pulling water in from your body, and that's causing diarrhea, it's causing cramping, and we want to avoid those in our patients. And all of these are generally higher risk when your patient has a J tube. For administration, we want to administer these medications one at a time. Sometimes people spit up, sometimes it kind of back flushes out of the tube. So we want to make sure we're tracking what we give, when we give it, so we're able to redose when necessary. And then flushing is our friend. It prolongs the life of the tube, it prevents clogging. And anecdotally, when I was in pharmacy school, I was constantly told, well, we can use soda water to flush our tube. It helps get rid of a clog. Very wrong, very wrong. So soda and soda water are acidic, and acidic liquids tend to interact with medications, causing them to clump and then ultimately clog your tube. So water is great. If we're experiencing clogs, you can use a pulsatile flushing method, and that generally does the trick. The ketogenic diet is also very common in our Dravet patients. Ideally, we're wanting to lower the amount of sugar that we're taking in. The problem is that liquids tend to have a high amount of sugar. We want those liquids to taste good. Well, unfortunately, generally, if it tastes good, it probably has sugar. So we usually convert to tablets, although some exceptions do apply. So in our patients with feeding tubes and patients with ketogenic diet, I wanted to just generally go over general crush and mix recommendations. So the first thing we need to do is stop those feeds, stop the tube feedings. And one of two things I counsel my families on. One, you can crush your tablet in your syringe. And that way we know all of the medication is in one place. The other method, sometimes we have tablets that are very difficult to crush. So in that instance, I recommend using something like parchment paper where the particles would easily slide off, making a little sandwich, and then crushing with something like a rolling pin. And then you would take that powder and subsequently put that into your syringe. If you use that method, I would rinse the parchment paper with a little water into your syringe as well, because we want to optimize the active part of that medication that your child is getting. So then you will draw up the water, give the medication, and then flush. Again, flushing is our friend, and then you can restart your feeds. Can we give it via gastric tube? Can we give it jejunostomy? Big question, right? That does affect efficacy. And some medications can easily be given both routes. Some can be given one or the other, and some shouldn't be given via enteral tubes at all. So we'll start with cannabidiol, for example. G-tube, NG-tube, into the stomach, yes, that is an option. Via the jejunostomy tube, it's not recommended. The absorption is affected, and it might not be as effective. So other little pertinent tidbits. With cannabidiol, if the tubing is made of PVC, that tends to harden and crack. So if you're administering cannabidiol, we recommend to avoid tubing that is composed of PVC. And it's easy to tell because your label should say it's PVC. Levetiracetam. This can be given via NG or J tube. The biggest thing, although liquid is preferred, it does contain malitol, which is a sugar alcohol. So if your child is experiencing side effects with this medication, one way to mitigate that side effect is to dilute it further with water, make it a little less concentrated. And then finally, a medication we're all probably very familiar with our kiddos, valproic acid. If you're using a liquid, you can definitely administer it, but we recommend diluting it further with water, again, to mitigate those gastrointestinal effects. You can administer it via the gastric routes. However, it is recommended that we do not administer via the J tubes because it affects absorption, and it's a narrow therapeutic drug. So we're monitoring drug levels, and we want to ensure that these drug levels are being absorbed reliably and consistently. This is an instance. This medication has a wide range of products, ranging from extended release, delayed release capsules, liquids, intravenous. This is an instance where we need to really pay attention to the label and figure out what form our patient is getting. The tablets that we use to crush are technically a delayed release tablet. I know I just told you don't use delayed release, but this is that one exception. It is enteric coated, so once you crush it, it acts like an immediate release product, and really it's our only option for patients on a ketogenic diet receiving valproic acid, as the liquid contains too much sugar. And then finally, if you must administer this via the jejunostomy, your physician may require further monitoring. We just want to make sure, again, that those drug levels are at the appropriate level for your patient. And then, of course, the most important thing is you guys, and that you have the resources at your fingertips. So in the upper left-hand corner, I wanted to just thank my colleagues, for Dr. Veronica Hood and Dr. Mary Vong. We collaborated on this reference site for our families with patients with Dravet undergoing surgery. And this really goes much more in depth than what I've discussed today. It has a fairly comprehensive list of medications, how you can give it, tube feeding tips, and how long you can potentially delay a dose if necessary. And then, of course, the Charlie Foundation, My Tube Feeding, Epilepsy Foundation, Feeding Tube Awareness, and Seizure Action Plans really set you up for success. And this is by no means comprehensive, but it's a good place to start. So in summary, life happens. Things happen. Things don't go according to plan. But just because your child has missed a dose or can't take anything by mouth, that doesn't mean you guys can't have a medication or that you failed or that you won't be successful. The key is staying on schedule as much as possible, but having a plan. As long as you have a plan, you are set up for success. Things we need to consider are alternative routes. We're looking at our timing options, enteral administration, and really having that conversation with your providers to come up with these options and plans. This is my contact information. If you have any further questions, I'm happy to answer any questions that you might have right now. Yes?
So I've heard mixed information with Epidiolex on whether we can give it all at once or whether we need to give it by itself and then wait 15, 20 minutes. Do you have any information on that?
Without knowing what your other medications are specifically, there may be an interaction, but generally I find it okay to give at the same time. I would never necessarily recommend mixing all of your medications in one syringe, but I don't see from a scheduling standpoint any issue in giving it around the same time on the same schedule. Obviously, we want to optimize the schedules for our families, and sometimes it is consolidating our medication administration times. And I'm so sorry, I should have repeated that question. Her question was, is there any issue with giving cannabidiol at the same time as other medications? So, thank you so much. All right, thank you so much.